child posted for convergent squint correction of right eye surgery, sir.
A short case scenario. So just to quickly go through what is the important history you want to elicit in this case.
Okay, sir. A 3-year-old female child weighing 16 kg from Tiruvallur informed his mother, reliable, with chief complaint of abnormal position of eye for past 2 years, sir. History of presenting illness. Patient was apparently normal 2 years back. Parents noticed abnormal position of right eye for past 2 years, which is static for past 2 years, which is not increasing or decreasing. The mother does not give any history indicative of impaired visual acuity, can estimate the distance, think, can identify shapes, can correctly identify color of the object. No history of trauma or head injury, no history of fever, URTA, skin lesion, no history of vomiting, excessive lacrimation or drooping of eyelid, no history of shortness of breath while playing. Antenatal history, patient is born out of non-consanguineous marriage, first baby. All trimesters were uneventful. No history of any drug intake, radiation exposure or trauma. No history of infection or any other illnesses during pregnancy. Patient was birth history, full term normal vaginal delivery, cried immediately, no associated birth traumas or any NICU stay for the baby. Immunization history, patient is immunized up to age. Family history, no significant family history. Development is normal. Nutrition is exclusively breastfed till 6 months, and feeding and weight gain is normal for age. General examination, baby child is alert, active, conscious and oriented. Weight is 16 kg, height is 94 centimeter. Pulse rate is 96 per minute, right radial, regular, normal volume. No pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. Dentition is normal, febrile to touch. Maybe no other associated limb or facial deformity. Examination of lip and spine appears normal. Airway, no apparent facial deformity. Mouth opening is more than 3 fingers. Modified Mallampati class 2. No restriction of neck movement. Teeth are normal. TMJ mobile. Temporomandibular joint mobile. Local examination. Frowning line appears on the forehead. Eyebrows are at same level. Right eye and left eye eyelids no drooping, normal. Cornea, both eyes bilaterally clear. Iris normal, dark brown bilaterally. Pupil is normal size and normally reaction to light. Conjunctiva is bilaterally normal. Sclera bilaterally normal. Ocular movement, restricted outer quadrant movement present in the right eye and equal quadrant movements in left eye. Visual acuity is 6/6 in both eyes. Systemic examination, CVS S1 S2 heard, no murmur. RS bilateral laryngeal plus equal, no added sounds. Parabdominal examination, soft, bowel sounds plus, no organomegaly or free fluid. CNS, higher mental function normal, motor and sensory normal, convergent squint in the right eye, reflexes normal, cranial nerves normal, no focal neurological deficit. Provisional diagnosis, a 3-year-old female child with complaint of abnormal eye position for past 2 years, static eyeball towards medial canthus in the right eye with restricted outer quadrant movement, probably a case of right eye convergent squint.
Okay. What is important, any history, family history you want to know in this case?
They can be strong
child with Squint coming for surgery. What are all the important family history we want to know?
They can be strong association of familial squint can be there for the people.
So what is relevant to anesthesia?
Convergent squint can be more prone for malignant hypothermia.
Family history of malignant hypothermia, very good. Any other musculoskeletal disorders? And Squint be a presentation of inherent musculoskeletal disorder? It is a congenital origin.
Duchenne's muscular dystrophy.
Duchenne's muscular dystrophy. Okay, it is one of the things which are associated with Duchenne's. Okay, so that is another important history that we want to ask. So you must rule out whether it is a simple, straightforward squint or it is a syndromic squint, like Duchenne's or family history of malignant hypothermia. That is the most and foremost thing. Or whether it is congenital or acquired is another thing. Why a squint should be operated? What are the reasons a surgery should be done for a squint?
One thing is for cosmetological purpose, parents
Very
will be
good.
very.
Whatever
Second is
it is.
patient may be suffering from diplopia or decreased visual acuity because of mechanical restriction.
Very
Uh,
good. Very good. Hmm.
then depth perception can be difficult for with squint patient. So to
That is
correct all these things,
uniocular or binocular vision. Okay. Then
yes.
any other reason? And the child's head become
Head
abnormally turned
tilt,
to one side.
head tilt or
Okay.
abnormal positioning of
Ah,
head can be there.
yeah, these are the three reasons why they have to worry about
Okay.
the surgery and do the surgery. Cosmetic, visual problem, acuity of vision, and third is the
Head
adaptation,
tilt.
like head turning to one side to make a uniocular vision instead of binocular vision. So that is all the reasons for the surgery. What are all the intraoperative complications that can happen during skin surgery?
One thing is pediatric patients, for most common complication is oculocardiac reflex for the baby. Uh, if the patient is on controlled ventilation, oculo respiratory reflex won't be there, but there is a chance of oculo-respiratory reflex. And post-operative oculoemetic reflex is more common in pediatric patient.
What is post-Duxton test?
Forced action is to rule out whether it is a neurological problem or due to mechanical restriction. The surgeon ophthalmologist perform a traction of the eye test prior to the surgery. Forced to
Prior
by
to the surgery. Prior
during
to the
just
intraoperatively,
just
is it done
like
intraoperatively or before surgery?
intraoperatively, sir, just
Ah,
before the incision.
intraoperatively. Ah, hmm.
Just before the incision, by holding the sclera, the surgeon will move the eyeball and see whether it is due to mechanical restriction or due to neurological problem the squint has occurred.
Okay.
Um,
So
so
what is
during
your role in that doing the post-section test?
one thing, succinylcholine is avoided in patient with squint who was supposed to perform a forced action test. Then the most common is oculocardiac reflex is more common with forced action test.
No, no, no. Post-section test. What will be requested by the surgeon to you as an anesthesiologist?
Relaxation, not moving, muscle relaxation, not movement of the eye, both will be requested by the surgeons.
You will have to give liberal
Adequate relaxation.
dose of muscle relaxant to
Also.
relieve any spasm or any restriction in the movement. So all the extraocular muscles, they are all striated muscles. So they will be relaxed with the neuromuscular blocking agent. But if
Yes,
it
sir.
is a mechanical restriction due to either fibrosis, that muscle will not relax. Okay, that will
Yes.
be still tight. So surgeon can find out that, and then he will be able to identify that muscle and do the repair accordingly. That is what is
Okay.
called the post-duction test.
Post-action.
What is Bell sign? Intraoperative Bell sign.
No ideas.
You have no idea. Okay. The eyeball gets rolled upwards. Some
Okay.
children and the lighter plane of anesthesia, the eyeball will get rolled upwards underneath the upper eyelid. So the surgeon has to pull the lower muscles to bring the eyeball to the neutral position. That is
Okay,
called
sir.
the Bell sign. So you have to deepen the plane of anesthesia or give a stiff dose of muscle relaxation, get rid of this complication of Bell sign. Okay.
Okay,
What
sir.
are the, how do you prevent that emetic problem? This is a very common thing in the post anesthesia period.
Yes, sir. One
What are
thing
all the
is
steps? Hmm.
you can give antiemetic for the baby.
Hmm.
Dexamethasone and ondansetron can be given
Then
for the
what
baby.
timing of antiemetic is very important. When will you administer the antiemetic?
Dexamethasone should be given initial time of the surgery itself so that the action will be
Straight away you go for dexamethasone or you combine it with multiple drugs.
multiple drugs, sir. Ondansetron
Ah,
and dexamethasone can be given.
yeah.
Ondansetron should be given at least half an hour to 45 minutes prior to extubation to have the full effect of ondansetron.
Better to start it as before induction itself. As you are inducing, you give a dose of your androstenedione and dexamethasone and repeat it at the end of the surgery. That is what is
Yes.
recommended to prevent the postoperative
No,
emesis
sir.
in this patient. Which is, can you give a regional block for this surgery?
Yes, sir. Retrobulbar block or peribulbar block will reduce the incidence of oculocardiac reflex in the patient,
That
sir.
reflects also. So you can definitely. Can you use ketamine for induction in this case?
Better
So are you going and making an incision in the cornea or limbus?
No, sir. Because the force reduction test.
You can use ketamine definitely. There is no
Okay.
contraindication because this is a totally extraocular procedure. It is nothing to do intraocularly. So you can safely use ketamine as a method to, because this child is 3 years old, there will be definitely separation anxiety from patient. So you
Okay,
can administer what is called the stunning dose of ketamine IM with
okay,
the
sir.
parents around the child and bring the child quietly inside and start an IV line and go ahead and do this procedure. Okay.
Okay,
What
sir.
type of
Okay, sir.
tube would you like to intubate the child, or can you use a supraglottic airway?
So both can be options, so supraglottic airway device or the tube, but both should
What
be
is
in
the
controlled
disadvantage
ventilation.
of using the supraglottic airway? If so, what type of supraglottic airway you want to use?
Proceal LMA is
Proceal for a 3-year-old child? I don't know whether it is available.
The chance of displacement because of shared airway, so
Shared
that is
airway, and once the patient is draped, it is very difficult to get an access.
access to
So
the
it is
brain.
better to, unless you are very well experienced in managing with the supraglottic airway, you should not venture that. And the armored LMA is the one which is recommended, so that it can bend nicely at the chin and will not be projecting straight like that.
Okay.
Intubation, which tube is preferred? Regular Protex tube or any other special tube you would like to use? You can use oral ray tube that will
Right.
flush nicely with that,
South
and
Pole.
draping will be easy. Okay.
South Pole.
So I will just show you the presentation on that.